What's going on, ladies and gentlemen? It's your boy Brad, and I'm back with another video. And in this one, what I wanted to do is I wanted to give you guys like a little case study with the overarching question being, what is the best pressor of choice for the patient who is in RV failure?
Are you listening? Nurse Pass. Beast mode. Grind.
This is more or less a situation that I was faced with probably 6 months ago, and I thought that it was a good one to chat about. So let's give you like a little list of hemodynamics as far as what we've got. So we've got a post-op CABG times 3. Patient has an EF of 30% and known right ventricular dysfunction. Intraoperatively, they ended up starting this patient on inhaled nitric oxide at 20 parts per million to try and dilate the pulmonary vasculature and offload the RV. So our initial set of vital signs that we get here. We're sinus tach at 110, and I'm reading vital signs over here. Blood pressure is 89/42 with a MAP of 57. Not good, looking hypotensive. Cardiac output 3.4, cardiac index 1.8. We have an SVR of 1700. Our CVP is 18. Pulmonary artery pressures 62/35. Pretty high PA pressures that RV's having to pump against. SpO2 95% on 40% FiO2. Again, 20 parts of inhaled nitric bleeding in. And as far as the drips that we're on phenylephrine at 80 mics. We're on epinephrine at 2 mics. Dexmedetomidine at 0.7 and fentanyl at 150 for sedation. So right off of the bat, taking a look at this, of course, we're in cardiogenic shock, right? Cardiac index is 1.8. SVR is elevated at 1700. That's likely contributing to our reduced cardiac index. You know, in this type of situation, this patient's on epinephrine. That's helping with positive inotropy. And you might be thinking a milrinone might not be a bad play for this patient. A little phosphodiesterase inhibitor. Help bring down that afterload while increasing inotropy, having a dual effect, right? That should reduce our SVR while also bringing up our cardiac output and our cardiac index. However, we know that it reduces SVR, so this is probably not going to be the best play for the patient who's already hypotensive. Perhaps we will trickle a milrinone in on this patient, but we need some sort of blood pressure support for this patient. Patient is hypotensive currently, and they're on phenylephrine at 80 mics. So this then circles to the question that I started with what is the best pressor of choice for the patient in RV failure? So this really comes down to some cellular mechanisms. You gotta dive a little bit deeper into the cellular pharmacology of these medications that we're talking about here. Phenylephrine, right, is an alpha-1 agonist. This is a GQ coupled protein receptor, ultimately leads to the increase of intracellular calcium availability and utilization to produce smooth muscle contraction. Phenylephrine agonizing alpha-1 receptors. Alpha-1 receptors are located all throughout your body, as well as your pulmonary vasculature. This is the key component here with a patient who's in RV failure. We need to offload this RV. It's pumping against a brick wall with those PA pressures being in the 60s/30s. We're already on inhaled nitric. Again, that is a pulmonary vessel dilator. So we're trying to attack the PVR, pulmonary vascular resistance, from that aspect, but we're hitting them with phenylephrine, which is clamping down those pulmonary vessels because, again, there are alpha-1 receptors on the pulmonary vessels. You might ask yourself, well, what if we did a norepinephrine for this patient? Okay, well, we know that norepinephrine has alpha-1 agonism as well as beta-1 receptor agonism at certain dosages. That's not going to be good either, right? We're going to be agonizing alpha-1 receptors. We're going to be clamping down those pulmonary vessels and increasing our PVR. What's another one? Well, this is the type of situation where you would want to use a medication like vasopressin. Vasopressin is going to be the most ideal vasopressor for patients who have RV failure. And here's why. Vasopressin is not a catecholamine like norepinephrine, or even epinephrine. It's not going to be agonizing any alpha or beta receptors. It's specifically going to be agonizing vasopressin 1 receptors. Vasopressin 1 receptors are also GQ coupled proteins. They go down this whole phospholipase C pathway to ultimately increase intracellular calcium availability and again produce smooth muscle contraction. But what's unique about vasopressin 1 receptors is they are not located in the pulmonary vasculature. They're specifically located in your systemic vasculature. So you're able to add a vasopressin onto a patient, increase their systemic blood pressure. So this blood pressure of 89/42 with a map of 57 suddenly becomes 100/60 with a map of 65. I'm just throwing this off the top of my head. But what's nice about it is it spares your PVR. So let's say we trickle a vasopressin into this patient and we start to work that phenylephrine down. What we're likely to see is an increase in blood pressure, an increase in MAP, a reduction in our pulmonary pressures because we're no longer contracting them down by agonizing those alpha-1 receptors with phenylephrine. And as we loosen up the chokehold that we have on those pulmonary vessels, well, now we're offloading our RV even more. There's less PVR, less resistance for that right ventricle to have to pump against. And what is this doing? Just by itself, if we're talking about just adding on vasopressin, minimizing phenylephrine, before we even talk about throwing a milrinone on the patient, already we're dilating out our pulmonary vasculature, we're offloading that RV, so we're having more right to left flow over to our left heart. Therefore, we're increasing our left ventricular preload. Remember, cardiac output equals stroke volume times heart rate. And one of the components of stroke volume is preload. That's one of the 3 components of stroke volume. As we increase that left ventricular preload, already we're going to be increasing our cardiac output and our cardiac index. So let's say we throw on the vasopressin, we minimize the phenylephrine. The PVR goes down, our pulmonary hypertension eases up. We have right to left flow. We have increased left ventricular preload. Now all of a sudden we're pumping out a cardiac output of 4.2 and a cardiac index now of 2.1. With that by itself, now our SVR is that compensatory increased afterload, that compensatory increased SVR is now going to ease up because we're now having more left ventricular cardiac output. This is an important thing to consider whenever you're taking care of patients who have RV failure. Often, very often, because it's just routine and it's what we're used to doing, and we cookie cutter treat patients, we're tossing a phenylephrine at them, or we're tossing a norepinephrine at them, without considering the nuances that come along with RV failure, with how they are so PVR sensitive, and how there's probably a better method of attack for increasing blood pressure while sparing PVR. I wanted to throw that little tidbit at you. I thought that it was an important one. It's a little tool that you can throw in your back pocket for whenever you're taking care of patients, specifically cardiac patients who have right ventricular failure. I hope that you enjoyed this video. I hope this little quick tidbit was helpful to you. If you did enjoy it, please leave a comment down below. If you have any, attestations of your clinical experiences taking care of patients with RV failure or any different variations in your practice that you've seen, please let me know down below. I'd love to hear it. Share it with a friend or a colleague if you thought it was helpful. And I look forward to seeing you guys in the next one. Peace.